Dr. Prabu Baskaran to go on.
After listening to the previous talk, I don't know whether we really need a Vivek and I. So anyway, if everything fails and you're not able to place an IOL, so we are here to help you out. Can you have the video? So I'm going to show two. I'm not able to see here. Yeah. So I'm going to show you two videos. This is case number 1. This is post small incision cataract surgery. AC maintenance is the first thing to do. I'm using our regular trocars, which I'm so used to in VR setup. After that, mark the meridians 180-degree apart, and I'm trying to open up the conjunctiva here. There is a large section over there. I'm trying to avoid that and trying to create a fresh one as much as possible. So tunnel creation is extremely important for XNET. XNET stands for extraocular needle guided aptic insertion technique, which I will be demonstrating shortly. So these side pockets are important because the needle has to come through that. So and open it. I'm sure all of you are good anti-segment surgeons here except me. So this is XNET device, the green thing what you see there. Enter, make the sclerotomy, go inside with a long customized 26 gauge needle. Once the needle tip is inside, that is a silicone stopper, dual protection silicone stopper. It temporarily holds the exteriorized leading aptic, which you will be seeing shortly. Use your McPherson forceps and gently depress the scleral lip, as you can see here, and try to make a sweeping sort of a motion. Once you complete the arc, it's like an arc. Once you complete, the tip is outside. Remember, do not try to penetrate the tissue, penetrate and come out, and simply dock the aptic of a 3-piece IOL into the lumen of 26 gauge needle. Around 2 to 3 mm of docking should be fine. Once you are good, try to retract the needle. At the same time, push the IOL inside. Do it, it should go as one unit. Retract, at the same time push it. You should not be separately retracting or pushing it, pushing the IOL separately. That's when probably the aptic-optic junction will become weaker, that you don't want it to happen. And remember, we have done something outside. We have done docking outside the eye, and we are not going to do anything inside the eye. And simply slide the dual protection silicone stopper close to the sclera and try to retrieve the aptic. Once you wait for the blue portion to be seen, hold it and disengage the needle. That's it. Single movement. Now the silicone stopper is on the aptic. You don't have to be dependent on the assisting nurse who may not follow you closely always. So when you're going to concentrate on the trailing aptic now, do the same maneuvers. Sclerotomy, these 180-degree sclerotomies are extremely critical to have a good centration. So bring the needle tip out by sweeping motion. Retrieve the trailing aptic, just retract and push it inside. Yes. It has gone inside now. Again 2 to 3 mm of docking. Do it. So remember, when you do this step, the tip of the aptic should be facing down and the needle should be receiving it. Then retract the needle. Again, wait for the aptic to be seen. Once you see the blue portion, the aptic, you hold it and gently retract the needle. This XNET device is exclusively done for SFIL, developed in collaboration with Aurolab. Now I'm introducing another device called S-Fix. Stands for suture guided aptic fixation. It has 3 parts. The yellow portion what you see is a polyamide tube. You can see the full device picture over there in the inside. Dock the aptic, push it inside, push, that's the second step. Push it inside till the complete polyamide tube is inside the eye. Then take a simple suture bite. Again, we are not doing anything intraocular. Suture and needle are something, as ophthalmologists we are so used to. So as an anterior segment surgeon, I'm sure you will be able to do this. Take a suture bite. Around 2 mm should be fine. Don't take a long bite over there at partial thickness sclera. So once you are done with the suture bite, retrieve it. Keep pulling. Retrieve the needle. The needle is out. Suture is out. Keep retracting the nylon suture. The polyimide tube comes out, again you will see that, but the aptic doesn't come out, it stays over there. It gets fixed inside the 380 micron, that's a suture needle size. The sleek suture needle track that you have created, the aptic is inside there. I am repeating it on the other side. You will see that's a polyimide tube which we have incorporated into the regular 380 micron suture with 5/0 nylon suture. So dock it, that's the first step, and push it inside, that's the second step. When you push till the entire polyimide tube is inside the eye, because the polyimide tube is not very flexible, so you need to ensure that it goes inside. The nylon suture is flexible. You can bend it, maneuver it, and take a suture bite, start from the point of sclerotomy and traverse for around 2 mm and come out. In case when you are, probably as a beginner when you are doing initial cases, you can always open the conjunctiva. In case if there is excess chemosis, again you can open the conjunctiva, visualize it comfortably, but I am sure after that you won't probably need it. Retract the suture, thread, as you can see here the thread comes out, polyimide tube will also come out, but the suture gets fixed. You will see that shortly. You can see the IOL movement of the optic inside, put retro and then visualize. Be convinced that the optic goes inside and the suture, you can see the blue optic gets fixed inside. Sometimes you will get to see this another, this is second case where I have done handshake technique to, it's a clear corneal SFIL, clear foldable SFIL. I have done handshake technique to exteriorize the optics. I am still using S-fix. So as you can clearly see, you don't need to open the conjunctiva, there is no need for peritomy, there is no need for flap, no need for glue, no need for flange. All you need is a S-fix device. Dock it, push it, and take a suture bite, starting from the point of sclerotomy. And again reiterating that in esophageal surgeries, if you want good IOL centration, there are two things that are important. One is the sclerotomy points that you make, which should be 180 degree apart and equidistant from limbus, either 1.5 or 2 mm, but it should be symmetrical on either sides. And then how symmetrical the optics are placed. So these are the 2 points that are extremely important to get good IOL centration, whatever be the technique. So now you can see the suture bite is done, and you retrieve it. S-fix has, so as you can see, S-fix has 3 components. One is 380 microns spatulated needle connected to a 5/0 nylon suture, and we have incorporated polyimide tube, 8 mm polyimide tube. So some amount of aptic, sometimes you will see it's actually good. You can actually push it inside. You can take advantage out of it. You can push, pull, and center the IOL at the end. So as you can see here, I am pushing it. Go to the other side, dock it. So remember, when you are doing this docking, there is a little bit of learning curve over there. Use 2 McPherson. Do not hold the hollow portion of the polyimide tube. You can see the polyimide tube, 8 mm polyimide tube we have provided. There are 2 components. One is suture fill 4 mm and suture free hollow portion. Do not touch the hollow portion. I am touching the aptic, and with the other McPherson I am touching the suture filled polyimide tube, because the polyimide tube can get kinked. So push it inside after docking. Do not worry about the IOL, it's not going to fall, because the aptics are, as you know, it's a curved thing and the polyimide tube is straight. So when you try to push the curved thing into your straight thing, it gets snugly fit. Also the dimensions are meticulously designed in such a way that this disengagement will never happen when it is inside the eye. Suture bite and retrieve. So remember, the suture bite has to start from the point of sclerotomy and traverse around 2 mm. It should be good. Don't take a long bite. That's when the optic tip will get missed somewhere inside. Then you will find difficulties in centration. So I prefer to take a short bite, so that I would intentionally want the optic tip to be seen outside for me, outside the conjunctiva, and then at the end I can sort of push it inside and tighten the IOL for good centration. Thank you. I just want all of you to question yourself whether you can repeat the surgery when you go back home. I'm sure the answer is going to be yes. Thank you.